So, to me, no, there's no reason or anything. There might be, I might post a very small podcast, but it probably will not be on that Tuesday. It may be over Thanksgiving. I kind of would like people to have a break over Thanksgiving weekend, so, but we'll see how that goes. So I think, again, whatever we do today and tomorrow, that's where we go for Tuesday for the test. All right. We talked about amniotomy, and this is done by the provider. Sometimes this is accidental. So in other words, it happens when I'm doing a vaginal exam. That's one of the reasons why we don't want to do a lot of unnecessary vaginal exams. So we had a question over here about clarifying about whether or not to do vaginal exams pertaining to pain medication. So I just want to revisit that for a little bit. The purpose of doing a vaginal exam prior to giving IV pain medication is you want to know kind of the labor status. So we need to know how far she's dilated and if she's making progress in her labor. Because if I give IV medication to mom and she delivers very soon thereafter, that IV medicine is systemic and it's going to go through the placenta and affect the baby. And so the baby's going to need more resuscitation. It used to be that in some cases, some providers would say, you know, you're 9 centimeters, you're too close to delivery, so we can't give you IV pain medication. In our facilities here in town, because we have NICU and we have the means to resuscitate babies and things, they aren't quite as restrictive, but you may see that in other parts where maybe you might be in an area that doesn't have nursery staff or the means to resuscitate the baby. The patient wanted an epidural and she was 9 centimeters. Some facilities would say no, because by the time you got the epidural, she may already be moving toward delivery. But in our clinical experiences, they get them in so quickly and they take effect so quickly that a lot of times anesthesia will go ahead and put epidurals in, even though a patient's in transition. One of the things about transition, what's the position we put the patient up in for an epidural? We put them in an upright position and set them up, and gravity works, and so a lot of times that just causes labor to go that much faster. The baby puts more pressure on the cervix, and she ultimately delivers. So you kind of don't want the patient to go through a procedure that doesn't give you the therapeutic effect. You hate for that to take effect after the baby's born, because the whole point of the epidural is to alleviate pain with contractions. So again, with pain medication, we would anticipate that the patient's pain, the pain is not from the procedure of amniotomy, the pain is now from the bag of water's broken, and so now the nerve endings in the cervix, the baby's head is pressing against the cervix. We usually will see things progress with the cervix starting to open up and dilate, but this also means it'll be more uncomfortable for the patient if she does not have anesthesia. So any questions about that?
I just have a quick question about positioning of the woman in pregnancy. Before we would give her any of the pain meds, stuff like that. Can she just change her position to anything that she wants to? She can sit up. She can do anything she wants.
As long as the baby tolerates whatever position she's in, we just don't want people flat on their back. I don't know, some facilities use the Bishop score. Have any of you talked about it? Have you seen any documentation anywhere about Bishop score? I brought this in because clinical instructors asked me to bring it in, and sometimes I think it just confuses students. Please do not memorize this. I would never ask you to grade or provide a Bishop score. I would give you a scenario like APGAR. But I would suggest, knowing that if you have a very low Bishop score, then usually you need a cervical ripening agent. If you have a high Bishop score, and notice again, high meaning the highest you can get is 9, I think. With that, the higher the Bishop score, the less intervention you need. So when you have a very low Bishop score, this is somebody that are closed, long, baby's high. That's somebody who's probably going to need a cervical ripening agent like Cervidil, Prepidil, Cytotec, mechanical ripening with a catheter balloon. But if you have a patient who has a higher Bishop score, usually like above 7, 8, something like that, then often they don't need that. They're going to probably go straight to Pitocin. We do not give Cervidil and Prepidil to patients who have ruptured membranes, okay? So, and I'll probably throw in Cytotec with that too. Once the water's broken, we usually go straight with Pitocin. At least that's been my experience. So let's talk a little bit about Pitocin. The whole reason to give Pitocin is to cause contractions. The reason we like to use IV Pitocin is that we have very precise control over it. Pitocin has a short half-life, and so what that means is if I need to turn it off, it dissipates in the patient very quickly, so contractions will slow down and stop. But ultimately, what I'm looking for when I'm giving Pitocin is to help contractions be effective, whether it's the frequency, the duration, the intensity, but I also want to see cervical change. So that's really the whole reason why I'm giving Pitocin. So the goal is somewhere around 3 contractions within about 10 minutes, and those contractions are lasting about 60 to 75 seconds. So Sarah mentioned that with the IEPC, that there was a score that they were looking at, and that kind of helped guide the decision about what to do with the Pitocin. And so they turned down the Pitocin. And so this is a great example of, sometimes Pitocin goes up and we go towards delivery, but again, the nurse needs to use judgment and make decisions, and in this case, they actually turned down the Pitocin and got a delivery. So the nurse is the one who titrates the Pitocin. And that's why I'm making such a big deal about it, because as a nurse, you need to use your judgment about when to turn the pit up and when to turn the pit down. So it's not absolute. It's not once I get to 8 milliunits that I always stay at 8. You'll notice here, like in this situation, we went up by 2. Depends on the order. Sometimes the order is to go up by 1 milliunit, sometimes it's to go up by 2 milliunits. The other thing, I don't know if you noticed, but Pitocin is always given as a piggyback. Now, in your frame for med-surg as a piggyback, you're thinking of antibiotics. That's a very common IV piggyback. Other medications, so we give it up above the pump, right? You have the pump and it piggybacks into the primary line. When we give Pitocin, it's on a pump, but we actually put the Pitocin in at the lowest port closest to the patient. And again, that's because we don't want a whole line of Pitocin when we turn the pit off. So we'll often have our primary fluids, we have Pitocin, they're both on pumps, but that Pitocin line is plugged in at the lowest port closest to the patient. Does that, folks who saw patients with Pitocin, do you recall seeing that? If you didn't, that's okay, but the next time you're in labor, you have a patient with PIT, you might take a peek at that. And the reason why is because Pitocin is given in very, very small amounts, and so you have to have primary IV fluids to help that very small amount get to the patient. So for example, with this concentration here, we talked about milliunits per minute. And so when you have 20 units in 1,000 milliliters, as an old fogey like me, I know that for every 3 milliliters per hour, that's 1 milliunit per minute. Well, 3 milliliters an hour, that's not even a teaspoon. So I have to have primary IV fluids to get that amount to the patient. So that's why you have that. Now here, why would they use this concentration? This particular concentration, it's a 1-to-1. So in other words, 1 milliunit per minute equals 1 milliliter per hour. So what's the advantage of that versus this? We are lazy in communication in labor and delivery. And so if I say the pit's at 10, or let me change it, pit's at 12. If I say the pit's at 12, do I mean 12 milliunits per minute? Or do I mean 12 milliliters per hour? And that could cause miscommunication. So having it be 1-to-1, there's no math, we don't have to worry about a miscalculation that somebody upped one fluid and they didn't do the other and there was a mistake there. So it's a safety issue as to why they've gone to that different concentration. The other thing is, one of the things about Pitocin, you may have noticed this on your drug card, but it mentioned something about water intoxication as a side effect. We don't see that very often, but that's another reason why I haven't seen this used very often. And it's again to kind of decrease the risk of getting water intoxication. We used to have people who would be on Pitocin for, 12, 18, 24 hours. And so if you're on Pitocin a lot and then you get a lot of Pitocin afterwards, that's where the water intoxication could be a problem. But generally for us, we don't see that because in labor at least, we have small amounts that we're giving. Now, when we talk about Pitocin, generally labor nurses talk about it in milliunits per minute because our order guides us there. So it doesn't say milliliters per hour, it's milliunits per minute. And so the idea is that I would adjust my pump. So now if I have a smart pump, I might be able to go ahead and just put in I can have it read where it actually says Pitocin, and it automatically does the math for me. But not every facility has a smart pump. Some of them just have plain old regular IV pumps, so I have to do math to be able to calculate that. Now, what I posted for you up on Moodle was an example, and this is the way that I do it, and like my good friend Lori Minton, when she sees this, she like wants to pull her hair out, and I totally get it. Like, I see where a lot of people would not want to do math this way. You're like, who in the world would ever set this up? But it's using dimensional analysis, and one of the things you'll notice is that I do everything. I put everything there, and I make sure my units of measurements cross out. So I know that 60 minutes over 1 hour is 1. But I have to get rid of minutes. So I always try to think about what's my end result, what am I trying to figure out at the end, and I need milliliters over hour. And so what do I know? And I put that at the front, and then I work my way across and kind of reduce. But what I would suggest if you're going to use this method is you multiply everything in the numerator first, you multiply everything in the denominator second, and you divide at the end. I think a lot of folks try to reduce in the middle, and you get these wonky numbers. And so I would suggest kind of figuring this out across. And then the other thing with the example is, in some of our facilities, the pit goes up, the primary fluids stay at the same rate. So the folks that had Pitocin yesterday, your primary fluids, did they change at all? No. Okay. In some cases, and again, it just depends, when the Pitocin goes up, the primary goes down to keep the total IV fluids at 125 milliliters per hour, or whatever the rate that's been prescribed. So every time that I bump up the pit, I have to lower the primary fluid. Now, we're seeing less of that, and I think, again, part of it has to do with there's a lot of room for error. And so people are adjusting the fluids in the wrong way. The other thing is, sometimes we have a situation where you have a patient who gets primary IV fluids, they're getting Pitocin, and then they're also getting max sulfate. So if I'm having to give all of that at the same time, that's a lot of fluid. So again, I may have to adjust those fluids, because one of the issues when we talk about max sulfate is fluid overload. Does that make sense? So you're like, why in the world are you having me do this? Because I don't do that in clinical. Well, we're gonna do intrapartum at risk, and there are reasons why we would give a patient MAG, Pitocin, and IV fluids at the same time. It's like a critical care type patient. So what can I help in terms of math in regards to Pitocin? And if you haven't had a chance to look at it, that's cool. I would encourage you to look at it and shoot me an email, or I'm happy to meet with you. But I think seeing it in clinical is sometimes very helpful because then you get an idea. And I think this idea when you work with the labor nurse and just recognizing, how often they go in and adjust the rate. So for example, we might go in and adjust the rate every 20 or 30 minutes. And so we doubled it 2 to 4, but notice we didn't double it again. We only went to 5, or wanted to go to 5, but didn't get to 5. Was that what I heard?
Yeah, we didn't get to 5 yet because then she had baby in between.
Okay. Wow. I guess she spit the baby out.
Yep.
Yeah. Okay. Question over here.
Never mind.
Okay, that's okay.
I have one.
Uh-huh.
On the primary IV fluid, how do you, seeing patients?
So if
how
you'll
do you calculate
notice, like up here, the 27 and the 98, the 18 and the 10, there's an order that says total IV fluids must equal 125.
that? Oh, okay, I got you.
And so if I figure out my Pitocin, then I know what the primary rate needs to be at. It's not just my decision, it's in the order. Yeah. I've seen some patients, they have ordered to keep their fluids to 100 milliliters per hour. 125 is kind of a classic. I think most places are using 125. That's been my experience, is 125, so.
Will we have to memorize any of these rates or anything, like on the test?
No, but you would probably be given a question that looks a lot like this. bunch up there. So, your facility uses pre-mixed bags of Pitocin, 20 units in 1 liter. You're caring for a client being induced with Pitocin. Per protocol, the total IV fluid should not exceed 125 milliliters per hour. The Pitocin's at 9 milliunits per minute. What's this equivalent to milliliters per hour? So you have everything there to do it mathematically. So there's not much to memorize. But I will tell you, the labor nurses, they memorize, because I'm not gonna change my concentration at my facility. So they know it's a 1 to 3, they know it's a 1 to 1. Okay. So for example, if I had a patient, she was at 9 milliunits per minute, then that would be, the Pitocin would be at 27 milliliters per hour in that concentration. So if I bumped it up to 10 milliunits per minute, the rate changes by 3, so it would go up to 30 milliliters per hour. There's just a lot of steps, you gotta have attention to detail. What I would suggest you're careful about is sometimes it asks for milliliters per hour, whoops. Sometimes it asks for milliunits per minute. So just kind of be mindful of that.
So basically like milliliters per hour, then just divided by 3 and you get the microunits?
It depends on the concentration,
Okay.
because your concentration, so in other words, that 1 to 3 only works with this one, it doesn't work here.
So that would just be 1 to 1. Okay.
But that doesn't work with this. So that's the thing, if you memorize one particular type of concentration, you might get burned if that concentration is not in the question. So, I don't know, did you all have that discussion at all about like heparin drips and how heparin, like the concentration of heparin in the bag is often consistent? Pitocin unfortunately is not. Insulin is another, so insulin and heparin drips, sometimes can be some variability in how the bag is mixed. So you always wanna look at the concentration in the bag to help do the drug calculation. It looks scarier than it is. I think again, just being very kind of methodical with it. So when it comes to Pitocin, you wanna assess mom. So with mom, we would wanna know, again, her vital signs, her experience with Pitocin. Has she ever had Pitocin before? What does she want for pain? What type of labor experience does she want to have? Because remember, with Pitocin, we have to continuously monitor the baby. The other thing is, I'm not gonna cause a stressor on the baby who can't tolerate contractions. So in other words, let's say I have a baby who has absent variability or has late D cells. I'm not gonna put Pitocin on top of that and make that stressor worse and cause fetal distress. Does that make sense? Okay. And then the other thing is, it's always ordered by the physician or healthcare provider. With Pitocin, I can turn it off if I deem so as the nurse. So in other words, the heart rate was 140s. It crashes down to 70. My patient's on Pitocin. One of the first things I'm gonna do is turn that Pitocin off, because I don't wanna cause any restriction of circulation to the baby. I want contractions to stop. Okay, I don't need it, that's an automatic. Now, we turn it off, the baby's heart rate goes back to normal. It doesn't necessarily mean I have to start completely over. I might be able to resume the Pitocin. So you're gonna see your nurses do a lot of different things with Pitocin, which I think is part of the reason it's a little bit confusing for students. So notice here that in all of our examples, we actually started at 2 milliunits of Pitocin, but in this situation, we actually dropped down, and it's because we had data to say too many contractions. So tetany means that I don't have enough rest between the intensity of the contraction, the duration, the frequency, something's there, and it's too much. So actually turning down the Pitocin provided adequate space between contractions. It allowed the muscle to be more effective to help the baby descend appropriately, get in position, and deliver. In this situation, we bumped the pit up. We thought we were gonna bump the pit up again, but we got to delivery too quickly. So we had a happy baby here, right? And then in this situation, we did 2 milliunits and went up by 2 every time. And then how often would you say that you bumped it?
Probably like every hour.
Okay. So you can see that in Christina's situation, there was a little bit more of a gap. And so as a student, you may be thinking, okay, we bumped the pit at 10, at 10:30, we're gonna go in there, and the nurse seems kind of lackadaisical about it, like, we didn't go exactly in at 10:30 and bump the Pitocin up. We do have a little bit of latitude. Some nurses are real aggressive, they bump their pit up really quickly. Some nurses are a little bit slower, because again, the whole issue with Pitocin is you have pit receptors in the uterus, and if I saturate them too much in labor, you're not gonna respond to them after delivery. So anybody who gets Pitocin in labor is at risk of postpartum hemorrhage after delivery. The higher amount of Pitocin you are in labor puts you more at risk. These are relatively low amounts, so that does not raise a red flag for me. If you have fetal distress, the easiest thing to do first is to reposition the client. I would not do the steps in the order that they're listed here. A badge exam is not always done for fetal distress. It just depends on kind of what the situation with the patient is. The other thing is, sometimes if there's something like a prolapsed cord with the baby, when I do a badge exam, I can actually feel the prolapsed cord. When I do a vaginal exam, sometimes the stimulation of the baby's scalp will cause an increase in the baby's heart rate. So that's the rationale for that. But I wouldn't necessarily say that we would do that first before turning off the pit. In my experience, we would turn off the pit before we do a batch exam. The other thing is you gotta look at the cause of your decel. So for example, let's say that you have late decels, but it's due to maternal hypotension. Does turning off the pit do anything? It does not, because you're not alleviating the cause for the decel. If you have maternal hypotension from an epidural, you need to give her a fluid bolus, and you may need to talk to anesthesia about ephedrine. Pitocin's not gonna do anything. And then after delivery, we're gonna give a much larger amount. And generally, all patients will get Pitocin after delivery. So you may have somebody who didn't get pit at all in labor, but she'll get pit afterwards. And I think, are most of you seeing that, Pitocin after delivery? Question?
Yeah, I was just wondering what the, like, if you said a higher dose, but what would be like a normal higher dose?
So when we talk about after delivery, we do not use milliunits per minute. So we usually will put like 20 units in 1,000, and we bolus that in. So you might see the pump go to 999, or they just open it and take it off the pump. We can even use a pressure bag, and it just pours in as quickly as possible. We usually bolus in a couple hundred milliliters. The uterus should respond pretty rapidly, because again, Pitocin has a very quick action. And if it doesn't, then that's when I go to my other medications. But you would never need to worry about milliunits per minute after delivery. It's only during labor. Anything else about PITs? All right. So what are some other things that could help stimulate or induce labor? One of the things that we can encourage patients who are post-dates after 40 weeks, 5 days, 41 weeks, is actually to have intercourse. The action of sex, sometimes having an orgasm will cause contractions. There's semen, in the semen there's prostaglandins. It's kind of like your own little Prepidil, Cervidil at home. It allows you to be intimate with your partner before your little baby comes into the world. Most people aren't too fussy about intercourse. When you have breast and nipple stimulation, that causes the release of oxytocin. So again, it's kind of your endogenous Pitocin. It's not on an IV pump. I'm not hooked up to all these cables and wires and things like that. The flip side of it, though, is sometimes, again, it can cause very intense and strong contractions. And why is it also important to know this? There are some women we don't want them to have the start of labor. So if somebody's at risk of preterm labor, we would discourage this before 37 weeks, because sexual or intimate activity may start causing contractions early. So if you're at risk of preterm labor, we would discourage sexual intercourse, intimate activity. But once you get past 38 weeks, you're in term, the risk is gone. Okay. Herbal remedies include evening primrose oil, raspberry tea. My experience with raspberry tea, it's not the stuff you buy at Kroger. It's actually loose tea leaves, very concentrated. I've known some women who have drank a lot of raspberry tea, and sometimes it works and sometimes it doesn't. So I do think some of it is just kind of Mother Nature and trying to get things started that either are ready to go or not ready to go. Acupressure and acupuncture. Again, there's some cultures that believe in using certain pressure points that can cause the stimulation of contractions. You can also see acupressure and acupuncture used as a pain management technique as well. So again, sometimes you'll come in and you'll see little pins in certain points, and the idea is that that will cause labor to start.
Is that similar as the same injections maybe?
I think it's on the premise of those particular, like dermatomes will then transmit nerves to the brain, which will cause the neurotransmitters to act certain things, whereas the sterile water is more so kind of like gate control theory, and it's like you have this sensation here, so it blocks the sensation from the contractions. So it's kind of a pain relief, but yes, to some degree, yeah. So amnioinfusion, with amnioinfusion not done very often, so this would be somebody who, this is not a routine or expected procedure. There needs to be some indication for it. In general, the most common cause for it is variable or prolonged B cells. And the most common thing that it's going to alleviate is cord compression. With amnioinfusion, it's delivered via IUPC. In the state of Kentucky, nurses are not putting in IUPCs. Has anyone seen a nurse put in an IUPC? We used to be able to, and they changed the scope of practice because the insertion of an IUPC has some risk associated with it. We can perforate the uterus, you can cause trauma to the baby, so you wanna make sure that the person doing that, and they try to put the IUPC along the fetal back, so it kind of runs alongside the baby. But it picks up changes in the pressure inside the uterus. There's also, again, there's an opening, I can't think of the fancy word for it right now off the top of my head, lumen, there we go. There's a lumen in the IUPC that you can put sterile fluid in. We would only put sterile fluid inside the uterus. And so you can restore some fluid around the baby and the cord. So if I have an amnioinfusion, I should see an improvement or a resolution of the variable D cells or prolonged B cells. A long time ago, they used to do them for meconium stained fluid. So anybody who had the bag of water ruptured with meconium, they would get an amnioinfusion. And they found that actually that could make the meconium aspiration in some babies worse. So you don't see that as much anymore. With this amnioinfusion, a lot of times you will just titrate the amount that's infused. So they may just get a small amount. In some cases, they just put like 250 milliliters in, and then they kind of wait to see how the baby tolerates that. In terms of an amnioinfusion, whenever we put fluid in, we just wanna make sure the fluid comes out. You don't wanna keep putting fluid into the uterus and see the uterus get larger, 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 because that's gonna put your mom at risk. So, I know you had mentioned an amnioinfusion. Has anybody else had a patient with an amnioinfusion? Yes, and do you know why your patient had it, Olivia?
She had variable B cells.
Did it take care of it?
Yeah.
Good, good. Did she tolerated it okay?
Yeah.
She had
an
an epidural?
Yeah.
Okay.
She didn't really know what was happening.
She didn't?
No.
Okay, okay. And when they did the amnioinfusion, how much did they get, do you know?
1,000?
They gave quite a bit. And then did it keep going, or did they stop it after 1,000?
It kept going.
It kept going?
Yeah.
Okay. And then, did you deliver?
Yes.
Did you take the IUPC out?
No.
So it stayed in the whole time?
Yeah.
She delivered the baby, and the IUPC came out with the baby?
Mm-hmm.
Okay, and everybody was fine?
Yep.
Perfect. I always like when the story ends well, so. In some cases, I have seen where the physician, as we get really close to delivery, so they'll take out the IUPC, but sometimes they need that to be able to know exactly when the contraction's occurring. But sometimes what will happen if you lose the IUPC or you lose the scalp electrode when it comes time to pushing, we can reapply the external monitors. So for example, if we lost that IEPC, like if it came out or was not reading, they might pull it out, we can put the TOCO back on mom. You could not give an IEPC with a TOCO is an external monitor, okay? Episiotomy. Episiotomy is a cut made by the healthcare provider. It's usually done when the baby's crowning. The purpose of this is to hopefully prevent a tear or a laceration. Some folks had the belief that by cutting, it prevented a tear all the way down to the rectum. But as we looked at evidence-based practice, I actually found that it's kind of like a zipper, and so once you've kind of made the cut there, it just tends to kind of keep going. So again, it's a judgment call by the provider. Certainly, patient would want to have some conversation with their healthcare provider during pregnancy to see at what times and when would an episiotomy be done. An episiotomy would not be performed in stage 1 of labor, which is not fully dilated, okay? And the other thing is we would never, the patient wouldn't need an episiotomy to deliver the placenta. It's really just to deliver the baby. If you're gonna have a vacuum or a forceps delivery, you're more at risk of needing an episiotomy. Most episiotomies are midline, and with midline, that means they go from the vagina down towards the rectum. They can also be mediolateral. Mediolateral's off to the side, and it's gonna actually go through more of those kind of pelvic floor muscles. So again, the belief with a mediolateral episiotomy is you're less likely to tear it down towards the rectum. But if you were to ask my professional advice as a nurse, I would say I would really discourage episiotomy. Very painful, swollen, high risk of infection, pretty uncomfortable for the patient. Forceps, anybody have forceps delivery? We don't use them very often. I think a lot of folks don't realize that the forceps actually are usually separate. So there's like, they look like 2 spoons. They put in 1 spoon at a time, they clamp the handles together and then literally pull. So you have these big giant metal spoons up across the baby's head, and you're pulling on the baby's head. And so that's why my good friend Rich Schwimmer, who's a pediatric neurology person, really gets kind of a queasy feeling in her stomach when she finds out a kid has had a forceps or a vacuum delivery. Because the concern is, again, not just even superficial trauma like lacerations, but again, is there some other kind of permanent neurological injury with a forceps or a vacuum delivery? Not used very often. It's usually only if there's an emergency or baby is so close that, again, they're trying to assist the baby out. Maybe mom is exhausted from pushing. She's not a very good pusher. Baby's heart rate's down, and they need to get the baby out. And there's different kinds of forceps. Not everybody uses the same kind. But a lot of times there'll be big cards, so we know that this provider uses Simpsons and this particular provider uses different, so everybody has their preference for what kind they use. The nurse does not apply forceps. And again, this is done in stage 2. Vacuum is used a little bit more commonly than forceps. We talked about vacuum actually being used during C-section. Anybody else see a vacuum delivery at all? A little suction cup on the baby's head. So again, not very common. With a vacuum, we try to put it again on the back of the baby's head. So the vacuum will be applied, suction's applied when she's pushing. We release the pressure when she's not pushing. And again, it kind of has a little handle and you kind of pull and sometimes it pops off. And as a nurse, you actually have to document like how many times it pops off and how much pressure is applied. Because again, we have seen some birth injuries result from babies that were delivered with vacuum. So I think Lori mentioned that in a C-section, she saw that the provider actually used it during a C-section. And the idea is, again, that it just kind of seals to the baby's head, and it's easier to grab the provider feels it's easier to use the vacuum to grab the baby that manner than using the hands, because with the amniotic fluid and blood, it gets real slippery, and they're concerned about hurting the baby that way. Yeah. Not a lot of, there's certain providers that they do their C-sections that way, and I think some of it too depends on how deep the baby is in the pelvis. So if it's really low in the pelvis and hard for them to reach, so.
They were really pushing.
Was a good sized baby?
No, 7 pounds.
Not a good sized baby.
But long time, you better hurry up.
Well, and you know, that's the other thing, because once you cut into the uterus, you've cut into the lifeline and the circulation's not getting to the baby. So people are kind of laissez-faire, but once they make the cut in the uterus, gotta move kind of quick like a bunny, so. So these are both complications from either vacuum or forceps. So if you had to choose for your baby caput or cephalohematoma, I would choose caput. Caput is swelling underneath the scalp. Cephalohematoma is blood, it does not cross the suture line. So your baby almost looks like it has a little goose egg. And with cephalohematoma, one of the big things that you'll see is that puts your baby at increased risk for jaundice, because they're bleeding into that space and they have to break down all those red blood cells. And cephalohematoma will take several weeks for that to go away. It's not always a quick. Caput, your baby has a little bit of a cone head, it feels real smushy on the back. Has anybody had a baby, they felt caput? So I think a lot of parents are like, gosh, my baby doesn't look anything like my sister's baby. Their birth pictures, they're so pretty and blah, blah, blah. And I think a lot of it, you have to realize, are hidden with caps. You don't see it because it's underneath the cap in the baby's picture. But babies, a lot of times when they come out, they kind of look beat up, look like prize fighters. They got vernix and they're just kind of squished and they look like, you know, kind of grumpy old people. And then in a day or two, they change a lot. Then you have all those newborn skin variations. So I think that's all normal and expected stuff. With our, with baby, you know, I think the big thing that sticks out for me, you know, a scalp laceration is concerning, bruising, but I would not want to have a brain bleed, you know, permanent nerve damage where you see, again, ptosis, like a droop in the eyelid, sweetness in the cheek, they're not able to suck. In mom, the big thing is perineal trauma. A lot, very painful with vacuum and forceps. So your patient may need to be redosed with the epidural, and then she may need more pain medication afterwards. So if you're taking care of a mom on another baby and she had forceps or vacuum delivery, she may need more pain medication. And then obviously any type of instrument that was inserted, a cut, is gonna put you more at risk for infection. So you're gonna watch your postpartum mom for infection. There are some providers who will give a prophylactic dose of antibiotics, IV antibiotics after delivery, just to kind of ward off infection if they do an instrument delivery, or it's also called a assisted vaginal delivery. It's forceps and vacuum. So C-section. We see a lot of C-sections in our area. We're trying to get our C-section rate down. But here are some reasons why you would get a C-section. So placenta previa means that the placenta is covering the cervical os. Os is another word for opening. So with that, we can't deliver the baby through the placenta. Placenta previa, a lot of patients don't know that they have it, so it's detected on ultrasound. So it's not like you can't just look at the patient and say, oh, you have a placenta previa. It's detected on ultrasound. CPD is cephalopelvic disproportion. And that's when the baby's head is too big for mom's pelvis. So patients who are at risk of having a baby like that would be someone who's post-dates, gestational diabetic, obese patient, an LGA, large for gestational age, that might be a CPD patient. Active herpes, I would put a little asterisk by that, because again, I think some of it depends on where the herpes lesion is, how large it is, but again, some of that is changing a little bit. It used to be once you had herpes, you were always a C-section, and they have found that there's actually more risk there doing the C-section, not risk from herpes, but risk from the C-section. Again, I'm biased through the lens that I have here in the Midwest. We tend to be pretty conservative, and I think there's a big concern about herpes transmission to the baby. So I've often seen women who had herpes, they would get a C-section. Has anybody had a patient in that situation, or has anybody had a patient that had a herpes lesion? I've also seen some really interesting things, like I had a provider once who put a 4x4, like a 4x4 in an ABD over the lesion. And we moved toward vaginal delivery to try and prevent any kind of microscopic transmission to the baby. But the concern about herpes to the baby, it could be very harmful to the baby. So that's why they say C-section. Placental abruption is another one that I would put a little asterisk by. And the reason reason why is with an abruption, what an abruption is, it means that the placenta is separating from the uterus prematurely. And usually what happens is the patient will have tremendous amounts of pain and you'll see fetal distress. But not all abruptions are C-sections. I'm gonna say that one more time, okay? So placenta previas, all placenta previas are C-sections, but not all placental abruptions end in C-section. You can have a very small abruption, like it'll say like a 10% abruption or something like that. Some women actually abrupt as they are delivering. So right at the end, you might have a woman who's precipitously delivering and she actually, the placenta rips away, but then the baby comes out like 2 pushes later. So we didn't do a C-section because the baby delivered. There was no reason to. In this situation with the placental abruption, what would make the decision is again fetal distress. The placenta has ripped away, there's no communication or lifeline between mom and baby, so baby's not getting circulation. We can do more for the baby outside the uterus, so it's a C-section. The other thing I would say about that is that would tend to be a emergency C-section. It's not a planned C-section for an abruption. And if you think about that, that makes sense. Non-reassuring fetal status, so that would be our babies who have late D cells, absent variability, they're not tolerating labor, they have recurrent prolonged D cells, and mom's not making cervical change, cervical progress. And then the last one is failure to progress. Another term for that that's used in our book is labor dystocia. The other thing with failure to progress, these are women sometimes who get stuck. So in other words, they are progressing along, but they only get to 5 or 6 centimeters dilated. The other thing that can happen, and this is, again, not a good place to be, but some women will get completely dilated and they will push, and the provider will make a judgment and say, no, I can't do forceps, I can't do vacuum, and they take the patient back for a C-section. So they actually labored all the way, they got completely dilated, they tried pushing, and they weren't able to push, and so they ended up with a C-section. So you kind of always want to know the backstory of your C-section patients, because a scheduled, routine C-section that's done, patient didn't labor at all, is quite different than someone who had a C-section for failure to progress. I haven't seen Healthy People 2030. Somebody was like, we need to get rid of Healthy People 2020, said that the other day, and I was like, gosh, I keep talking about it because I'm pretty sure it's one of our course outcomes and program outcomes. And looking at states with very low C-section rates, it would be places like Utah, Idaho, Oregon, Wyoming, Colorado, Ohio. States not so good, not the worst of the worst, but you'll notice Kentucky's down here at 33. The average C-section rate in Kentucky is 35%. So about 1 in 3 women getting C-sections. I think the other thing when you do hospital compare, I don't know if you guys ever did that with Health and Human Services, you can actually compare quality indicators in different hospitals. And so when you look at C-section rates here locally, some of our hospitals look pretty high. You have to bear in mind that the hospital you're looking at, if they have a high-risk population, they're gonna have a higher C-section rate because they're taking care of the sickest moms. They're taking care of moms who have twins, triplets, quads, so on. So you're gonna see a higher C-section rate there. So we really wanna get that rate down to 23.9%, so we got some work to do in Kentucky. And that's one of the reasons why this idea of once a C-section, always a C-section, we're starting to question that, whether that's really necessary or not. The other thing I've heard, urban legend, one of my students said that her doctor, this is the thing I always tell students not to do. My student heard that her doctor said to her patient, that the patient had her 3rd C-section, and the doctor said, you can't have any more babies. Everything still works, you know, and there are lots of people who have more than 3 C-sections, but the concern was the more C-sections you have, the more you're at risk for complications. You're getting older. It's just like any surgery. The older you are, the more likely you are to have complications. That said, I've also known women who have had more than 3 C-sections and have been fine. So I think that's, again, something as a patient, I would want to know my provider's philosophy on that. And then know, again, what was the reason why I had the C-section, and can I have a vaginal delivery after having a cesarean? this situation, we do not do vaginal delivery after. And the reason why is because with a classical incision, it is a vertical incision. And so there's a very high risk of uterine rupture. This is not done very commonly, and it's because, again, it tends to commit women to having C-sections after this particular childbirth. So the incision's made up high. You see a lot more blood loss, a lot more infection with this type of cut as well. And again, this would be critical to teach the patient that she would need to have C-sections for subsequent babies. We're at 20 after. Let's go ahead and take a break. Let's take a 10-minute break.